All right, thank you, Heide, for your kind introduction. And on behalf of our team, I would like to welcome every one of you to this first webinar session about Doppler ultrasound fetal CMR in congenital heart disease. In the next few minutes, I will be talking about the way we do these images here at our institution, what our imaging protocol looks like, and I will show you step by step directly on the DICOM viewer how we actually plan those images. All right, let's begin with a short introduction. As you all know, the gold standard for congenital heart disease diagnosis is the fetal echocardiography, but it can be limited, especially in advanced gestational ages, when the amount of amniotic fluid decreases or the bones become increasingly calcified. So there is desire for an adjunct imaging modality, and by principle, fetal CMR could close this gap, but it has the lack of a fetal ECG, which is required for direct retrospective gating for full temporal resolution of the beating heart. So we have indirect gating methods that were initially developed to compensate for this problem, but they are limited by time-consuming image post-processing routines and the need for specialized software. They are prone to the variabilities in the heart rate, whereas our new Doppler ultrasound-based technique offers a direct cardiac gating approach for the first time, thus overcoming those previous limitations. This is our device. As you all know, we have the transducer, which is connected via the cable to the sensor box unit, and we have the headphones. And this is the first thing we would really recommend to use, as it makes it much easier to follow the fetal heartbeat. Here's a scheme of our workflow we established at our institution. It's divided into 5 steps. The first thing, which is really important, is patient positioning, and in nearly all cases we place the women on the left lateral side. In our opinion, it has several advantages. At first, it is more comfortable for the most women, especially when it comes to claustrophobia. It prevents from vena cava compression syndrome, and at least it makes it easier to find the fetal heartbeat and to fix the transducer on the abdomen. The next 2 steps are to acquire some localizer images, a survey scan to estimate the fetal heart position, and then to place the transducer on the abdomen of the mother. Here is an example. We got the single-shot T2 TSE images on a complete transversal stack. And what we do now is we look for the mother's navel, which is in this slide. So we look for the mother's navel, and based on this position, we estimate the approximate distance to the probably best position of the transducer. So in this case, we have the navel, and the middle level of the heart would be 2 slices below the section with the navel. So we have to go 1 or 2 centimeters below the navel to find the heart. So with this information, we go back into the scanning room, we move the examination table out of the bore, and we try to find the fetal heart and place the transducer. In this case, we would have 2 options. One is on the right side of the mother and the other is on the left side of the mother. We chose the left side in this case because of the shorter distance to the fetal heart for an optimal acoustic window, and because in this way the transducer is like clamped between the abdomen and the examination table. All right, once this is done, we go back we go back and check the trigger signal stability on our sensor box. Then we place the reception coil on the mother, and we finally start the actual scan. This is a short overview of our standard imaging protocol, which is very simple. It consists of three main sequences. At first, we perform a standard basic scan in 3 planes, transversal, sagittal, and coronal, in order to assess the fetal position in relation to the long axis of the mother, and to plan the following T2 single shot images in a transversal plane and in another plane, either sagittal or coronal, for, as I already said, for the estimation of the fetal heart position in relation to the mother's navel, and for planning purposes of the subsequent balanced steady-state free precession CMR images, which is our main sequence to diagnose the heart defects and look for cardiovascular malformations. It's important to say that in most cases we only perform transversal CMR images, which can be supplemented, of course, by, for example, sagittal or coronal planes, if we need more diagnostic information, especially for the outflow tracts. But the standard is the transversal stack alone, covering the whole heart and the great thoracic vessels, because it is easy to plan. It is less prone to fetal movement than it would be the case for heart-specific views, and it corresponds to four-chamber view in our view, because as the lungs are not yet inflated, the heart of the fetus lies flat upon the diaphragm. So if we do just the axial images, it corresponds to a four-chamber view, basically. All right. Now we'll change to our DICOM viewer and show you these steps with a practical example. This is a case of a pregnant woman at gestational age of 35 weeks, and what we did is our basic survey scan in 3 planes. So we have the sagittal, the coronal, and the transversal ones. And what we do next is to plan the axonal single shot T2 images for the next step. As you can see here, we acquired these images, and this is the step where we look for the mother's navel and check the fetal heart position. Then we go back into the scanning room. We move the examination table out of the bore, and we try to find the fetal heart with our headphones. And once we found it, we place the transducer here on the left side and check the signal stability. We place the signal reception coil, and we leave the scanning room. And then we acquire those single-shot T2 weighted images in another plane. In this case, we did it in a coronal plane, and based on these two sequences or these two stacks, we plan the actual the axial scene stack, and yeah, this is our result. In this case, we have the senior images covering the whole heart, up from the basis of the heart to the supraortic vessels. And in this case, our diagnosis was a unbalanced atrioventricular septal defect. And yes, this is our approach, and thank you for your attention.
Thank you very much, Thomas, for your talk. We will continue immediately with Björn's presentation and Björn's talks, and then go afterwards into the discussion.
Yes, hello from Hamburg to all over the world. I'm happy to give you an overview, a short overview, because we're limited of time, how we perform fetal CMR in our institution. So the first thing that I would like to announce is that it's quite comfortable if you choose on the patient settings, that's a localizer. Oh no, what's now? Okay, something's happening. Okay, just 1 second. I try it again. Okay, I hope you can see it now. Heide, short signal, if everybody's seeing this.
Yes, we can see your slides.
So let's continue. So it's quite comfortable if you choose the head first setting in the overall patient settings you do before you start your MR scan. Because usually the mother is placed with a feet first position in the MR bore. And because the fetal position is just in the opposite of the mother, so it's upwards down. If you choose head first, then the fetus is in the upright and correct position, as you can see here on this sagittal localizer image of the mother. So I think this is a good clue to make the further planning easier. So these are now two examples, sagittal localizer and a coronal localizer, where you can see the fetus in the upright position. Here's the fetal thorax, nicely seen, and then you can plan your further imaging, like as Thomas said, with the two T2 weighted images that we also perform. You can plan it very nicely on these localizers in upright position of the fetus. So for those of you who would like to apply long and short axis view, I would like to give you a short introduction how you can use the long and short axis views and how to apply. I think it's very easy because the planning is identical to adult CMR. So you can just ask your technician if you're not very familiar with it, and your technician should be able to do it very quickly and easily. So for starting, we will need a pseudo two-chamber view. Pseudo because this is not a precise two-chamber view. This is a two-chamber view is only for further planning. So in this first case, we have, let's say, a lucky localizer, because this localizer image already shows the fetal thorax in a transversal slice. And you can see here the left ventricle with the left ventricle and the left atrium. And you can easily plan a pseudo two-chamber view by aligning your slice along the axis of this atrium and ventricle. So if you're not happy with your localizer image because the fetus is in a different position, then you have to first assess these T2 weighted images. It is a little bit easier, but you have to perform a 2 weighted sequence, which takes some time. So it's the same here. You identify the left ventricle and just plan this plane for 2-chamber view across the long axis of the left heart. What you receive then is this image here. So you can neglect these structures because these are abdominal structures. And this is the fetal heart here. This is the left ventricle, and this is the left atrium. So this is a pseudo 2-chamber view. And now we want to plan a 4-chamber pseudo view, which is important for further planning. So what you do is quite easy because you set the image plane just along the long axis of this 2-chamber view. And what you receive then is this pseudo 4-chamber view. It's pseudo because you can nicely see the left ventricle and left atrium here, but only parts of the right ventricle and the right atrium. So this is not a perfect 4-chamber view, but for further planning, this is all you need. So we got now this pseudo 2 and 4-chamber views, and then we can continue to plan our short axis view. And this is now the first real perfect axis we want to assess, and this is short axis. And you can easily plan the short axis from your 2-chamber view and 4-chamber view by setting the image plane or orientation just perpendicular to the ventricle in the 2-chamber view and also in the 4-chamber view. And what you receive then is this short axis image. You can of course assess multiple slices. In this example, I show you only one image revealing this short axis view. And with this assessed short axis view, you can then continue and plan a nice 4-chamber view. For this 4-chamber view planning, you need the short axis and again this pseudo 2-chamber view which you assessed before. And then you just plan your orientation just across both ventricles and again through the long axis of the left heart. And what you receive then should be a nice 4-chamber view displaying all the cardiac chambers. So of course you can continue then to generate a perfect 2-chamber view, and then you just easily plan your image plane across the long axis of the left heart here in this 4-chamber view, and again with a short axis view, and then you receive a 2-chamber view as well. So that would be how you perform long and short axis view, and this is very similar to adult CMR. So this is what we did when we started with fetal CMR, but as Thomas already mentioned in his presentation, I also think that performing axial transversal slices and views, it's a little bit easier and simple to perform because it gives you the information of the whole fetal thorax and not only one slice, but you have a whole image stack, and which is interesting to see the vascular connections and cardiac chambers. So this is then the second issue I want to address, how we perform axial views. It's quite the same as Thomas already explained. Sometimes we start planning of these axial views straight from the localizer images because it is time saving. And this works if you have nice localizer images, like in this example here, you got localizer images in sagittal and coronal orientation, and then it's easy to plan your axial stack just on these localizer images. If you're not happy with your localizer images because the fetal is in a different position, then you can plan first your sagittal and coronal T2 weighted sequences. But however, that will take additional scan time. Not so much, but at least these are some minutes for planning and image acquisition. So here you do the same. You're just planning your transversal stack. This is very intuitive and very easy, I think, for everybody. And if you do this, then you receive this stack of transversal cine images. So we chose 12 slices and we perform maternal breath hold to reduce breathing artifacts. And this is the result. And as Thomas already said, I think the advantage of this transversal stack is that you can see the vascular connections starting from the basis of the thorax to the apex, so from the aortic arch going down to the diaphragm. So as an alternative, you can also perform DUS-gated images from steady-state free precision sequences, but not using this dynamic view, so no cine mode. So this is when you set the heart phases to 1, let's say, then you receive these images and it displays you the same information, but it's time-saving. So if you only want this anatomical information and vascular connectivity, I think these DUS-gated images using no cine mode is quite comfortable because you see all the interesting structures and these transversal slices. And of course, you can do this in other orientations as well. So additionally to this transversal stack, you can perform these coronal stacks, where you can also see the great thoracic vessels with the aorta, pulmonary trunk, and the cardiac chambers to check connectivity, and also this sagittal view. And these three orientations together, I think sometimes it may be better, let's say, it may be better to have these three orientations instead of one stack of cine images, and the time for acquisition is similar for the actual cine stack or these three orientations using no cine mode. So it's up to you, and I think this is the personal preference what you choose. But this is, however, something I would like to show you what we consider quite nice approach. Okay, then another interesting issue is the aortic arch. There are three planning options to image the aortic arch to display it in a parasagittal view. And the first option is to use an axial cine stack or an axial stack of images plus a coronal image to plan the aortic arch sequence. This is how we perform it here in our institution. However, there's still the three-point method, which is a quite nice approach you could try, or the interactive or real-time mode, which we tried several years ago with a prototype of the DUS sensor. But for me personally, I prefer this axial stack and this coronal image. And I would like to show you the first option, how to plan it. So if you have your axial cine stack performed, then you can here see the descending aorta and the ascending aorta. And if you then acquire a further coronal view, then you can see the descending aorta here. And if you consider the images next to this image, then you can follow the aortic arch and just orientate your slice positioning along this aortic arch and the descending aorta, and also across the descending and ascending aorta in the transversal slice. And what you then should receive is kind of parasagittal view of the aortic arch, where you can also see the supraaortic vessels and the descending aorta. So this is this was our imaging protocol at 1.5 Tesla. We are running our fetal CMR at the 3 Tesla system since 2 years now. But this is our old protocol where these images came from. We are using 3 slices and with a negative gap, so this is overlapping slices, so that the aorta is inside at least one image. And the slice thickness is 5 millimeters. Of course, you can try also 4 millimeters, and we also applied 3 millimeters in several cases. But again, this is up to your personal preference, I think. Okay, then I think this is the last topic I want to address, the breathing of the mother. So this is the same fetus and the same mother, and the left sequence we acquired with free maternal breathing. and the right images were assessed by maternal breath hold. I think you can clearly see that the image quality is much better with maternal breath hold. So I would strongly recommend to give breath holds to the mother. And this sequence, I said, we acquire 3 slices, and for one slice, the image acquisition time is around 12 seconds. So that should be possible for your patients. At least here in Hamburg, women are tolerant for 12 seconds breath hold. Okay, I think that was the last thing I wanted to say. Then thank you very much, and yeah, I'm expecting. Me and Thomas are expecting your questions. Thank you very much.
Thank you, Thomas.
Thank you, Björn. Yeah,
Björn.
both.
Sorry, both,
Thank
yeah.
you to both of you. We collected some questions that have arisen in the chat in the meantime. So I'm just going to start shooting the first one to you, Thomas. If you don't mind, it would be great if you can switch on your video again, your camera, so everyone can see you. So the first question is coming from Beth from Cincinnati, which is, do you keep the headphones out of the room when done finding the signal?
Yeah, that's a good question. I'm actually not quite aware of it. I think in the most cases we leave it in the scanning room. And I think from a technical perspective, it doesn't matter, but I don't know if Fabian or Heide, if you know anything. But yeah, I think in most cases we leave it besides next to the scanner into the scanning room, and it's no problem.
Yes, that's completely fine. You do not need to take the headphones out of the room, but they should definitely not be in the bore on the table. They should be out of the table and out of the bore, but they can be in the room. Yes. Okay, then let's move to the second question from Lisa from Minnesota. She is asking how much time to acquire these images. Maybe this goes to Björn because it was during your talk. And what happens if the baby moves the position? I think that's a very, very interesting question to all of us.
Yeah, indeed. So the total time of our scan protocol should be around 15 minutes, but this is only netto time. So this is acquisition time only. And as you might have been realized, the real acquisition time is longer, and examination time, because the fetus may move indeed. And yeah, then you have to repeat the sequence. That is what we usually have to do, because we don't use a sedation for the fetuses. Some institutions do this, but I think in Germany this is not possible. So sometimes you have to repeat your sequence. And this image stack I showed you with 12 slices. So this is 1 breath hold per slice. So acquisition time is about 2 minutes and something, but you have to consider the breath holds in between. So should be done in 5 minutes, the whole stack.
Okay, maybe I just raise one question in between, because there was the question from Munes, Fares. Those are beautiful images. Are you using 3T or 1.5T? And how late in gestation are these? Because now there's coming up another question, which scanner you were using. I think this is important for all of us as well. Yeah. So can you comment on that, Björn, please?
Yes. So some images, so the aortic arch images, were assessed at a 1.5 Tesla system. These images are quite old, I have to admit. The axial cinestacks, they were from 3 Tesla system. And yeah, I think you can generate images with good quality on both field strength, 1.5 and 3 Tesla. It costed a little bit of time to find good imaging parameters, and I think it's up to you how you choose it. So you can change the slide thickness to get more signal. Otherwise, if you change your resolution, it might be a little bit too noisy. So I think, but this is up to you, what you prefer. But actually, we are only using 3 Tesla. Since 2 years, only 3 Tesla.
Thomas, do you want to add anything? Because I know that you also switched from 1.5 to 3 Tesla a while ago.
Yeah, but we only performed the 2 first scans ever on our 1.5 Tesla system, and since then we did our fetuses always on the 3 Tesla system, and we are quite satisfied with that. So we don't have really enough experience with the 1.5 Tesla system. Yeah, but we would recommend the 3 Tesla.
Yeah, there was just the question, Siemens or Philips. So I'm answering that. Both Björn and Thomas are using Philips here today.
We have another question that fits quite well in this topic, which is what coils are used. Maybe you can elaborate on that. Any special coils that you use?
No, we use no special coil. We use the standard body coil by Philips, and yeah, we place them just on the abdomen, and yeah, it's quite fine.
Yeah, same with us, standard body coil.
Okay, thank you. Okay, the next was from Vassem from Illinois. And Björn, you were already talking about the breath hold that you're using, and he actually asked, do you need to account for maternal respiratory motion with breath hold? And there I would like to add, what is your recommendation if you use breath hold during the scans?
I think it's important to motivate your patient. So we usually give a short introduction at the beginning of the MR scan, telling the patient that it's very, very important to hold the breath. So, and if she can't hold the breath for 12 seconds, the patient should just breathe out slowly, not like a huge amplitude of breathing. And then it usually works. And yeah, so there are you have some options to shorten the sequence if you want to. But I think 10 seconds should be possible even for pregnant women to hold the breath, and just give some breaks to the patients in between the breath holds. Do it not continuously. Talk to them, and then we have good experiences with this method.
Thank you. We have another question from Beth, which is, do you always scan after 30 weeks?
Yes, every one of our scan is after week 30. Yeah.
Yes, that's what I would recommend, because we did some scans which were below 30 weeks of gestation. It was something like 27, 28. But I think there are two limitations. First of all, it's amniotic fluid, which is quite which is much more than in the late gestational weeks, and this is why the fetus is moving much more, which makes it easier. And the dimensions of the fetal heart are really, really different from a scan, let's say, at week 35. So the growth of the fetus occurs in the very last weeks very extensively. So 28 or 29 weeks, you can try and you can do, but the risk that the scan is not satisfying is too high, I think.
Okay. Thanks a lot. We have another question from Malenka, which refers to the question we discussed before. I'm just gonna ask it right now so we don't miss it. Do you not lose the ECG signal when they breath hold? And I believe, Malenka, you mean the gating signal from the Doppler ultrasound device. But if it's wrong, just write a comment in the chat, please.
Yeah, Thomas, maybe I can start if you don't mind. That's a good question. Sometimes we have this problem indeed, but you can prevent this when you tell the patient not to breathe in too strong. That's what I meant with not such a high amplitude in breathing. So if you tell the patient, okay, hold your breath, but before, don't take a deep breath in or deep breath out, just breathe normal and then stop your breath. Yeah. So no extensive excursions during breathing, and then it works.
Okay, and then there's another question from Malenka from Leeds. Any tips on how to plan a transverse stack when a fetus is really curled up?
Thomas, do you have any ideas?
You are muted, Tom. Yeah.
Yeah, it's difficult. I think what is really important is to take your time to analyze the survey images and to be clear before you start with the planning of the scene images. How is the fetus lying in the abdomen in relation to the mother, and yeah, once this is clear, I would say it's easier to plan the axial stack, and just do one or two. You acquire the transversal planning sequence, the T2 rated planning sequence, and then you add a sagittal one, and maybe you add just another coronal one, so that you have 3 planes to plan the sequence. Yeah. No special tip. Yeah.
Yeah, and in cases when the fetus is really like bent in the abdomen, so maybe it could be an advantage not to acquire a transversal stack, but do single images with angulated. Maybe, I don't know. I think it's a compromise. If you do an axial stack, I think then you have to consider or to think about if you want to see the heart in the perfect view, or if you see the vessels which are further upwards in a nice transversal orientation, just angulate perfect to the structure which you are interested most in. That's what I would do. Or you perform 2 axial slices, one perfectly aligned to the heart, and the other when the upper thorax is like bent forward or to the side, then plan another stack for the upper part of the thorax. Could be a solution.
Okay, thanks so much. We have another question from Michelle, which is, do you think using localizers to find the fetal heart before applying the device has been critical, especially versus just listening with headphones until you have a stable signal, because the first one requires repeating some localizers?
Yeah, that's true, but in the first scans, we were just listening to the heartbeat by the headphones, and was just try and error, and in average it took 10 minutes in average to find the heartbeat, and since then we changed our workflow, and we do these localizer images before, and since then, and of course we practice quite a bit in the meantime, we need just 1 minute, 1 or 2 minutes to find the fetal heart, and yeah, that's so much time that we invest into the additional localizer scan.
But I think if the table is not moved out completely out of the bore, I think then you don't need a new localizer. You can just get the table in again, and the system just stored the position of the center. So correct me if I'm wrong. Maybe there are some other users which have who have different ideas, but you don't have to move the table completely out, and then it should be fine. You don't need a new localizer.
Okay. Just maybe for you as an information, we got the comment from Mika. I will surely try to do your workflow. Looks logic to do localizer and then put the probe as close as possible to the heart. We are struggling. Maybe this might help. So sounds good.
All right. A question from Hildo from Leiden. Any tips how to increase the blood myocard contrast?
So if you're from Leiden, Philips is quite close to you, I guess. If you use a Philips system. So what we did is we have very good support from our provider, and just switch the flip angle maybe to get a better blood signal, a higher blood signal. So this is trial and error. Sometimes you change something which should theoretically be better, but then in the real world it's worse. So from my point of view, just get good support from your provider and then try. It's just learning by doing, from my point of view. But flip angle could be a solution.
We have another one from Noah, I think. No,
Mike.
It's Ronak. Sorry, Ronak. I'm sorry. We're sharing our notes. So, do you prefer expiration breath hold or inspiration breath hold? Does it change image quality much if you choose one versus the other?
Okay, we prefer the expiration breath hold because it's more stable. The heart is in the following images on the same level, but I know it's harder to perform by the women. What we do is we take our time for good education of the woman before we start to scan. And we explain she has to breathe in and breathe out, and then to breath hold, and with that information, it works quite well.
Yeah. So we do prefer what the patient prefers. So if the patient is more comfortable with a certain breathing position, then we let her do what she wants. But it's important to get always the same. The same level of breath hold, and if it's inspiration or expiration, I don't mind. I don't think this is much different. But as you said, Thomas is correct. Expiratory is more similar.
All right, then there's another question. Are any special sequences or software needed for fetal CMR other than the gating device?
No, you just what we did is just we just looked for our CMR sequences from the adults and just modified them. That's what we did. So you don't need any other special software unless you want to perform 4D flow measurements or what else. But for a standard fetal CMR, you don't need anything else. You usually use with adult CMR.
Okay, thank you. The next question is from Nadine. Have you tried obtaining 3D non-contrast images set and work with that?
No, we have no experience with that. Maybe you, Björn?
Yes, but only bad experience. We tried it several times with different imaging sequences provided by our provider, but we weren't successful, so we stopped it. It was not successful.
Die haben wir schon. Dann nehmen wir die von.
Yeah.
All right. There's another one. Does the pregnant woman always lay supine, or do you try side lying to make breath holds, etc., more comfortable for the patient? Who wants to answer?
Yeah, I can start with my answer. So it's up to the patient as well. So it's up to them. It's up to the patient if she prefers supine position or left lateral. I don't mind. So I think the most important thing is that the patient feels comfortable, because then you can prolong the time she's lying inside the MR. If it's not comfortable, the patient will stop after 10 minutes. So make it comfortable for the patient, and then you have the best results.
Okay, we do it in nearly all cases on the left side, and all of our women we scanned yet were comfortable with that, because I think it's especially for claustrophobic patients, it's easier to not look directly on the side of the bore, but yeah. And another point is, as I already mentioned, if the woman is lying on the left side, you can clamp the transducer between the abdomen and the table, and so it's unlikely to slip out.
Okay, next question. Have you attempted angiography with either 3D SSFP or 3D black blood with maternal respiratory navigator? Any experience on that?
So what we did is to do phase contrast angiography, 2D, and for several months, or no, it's about 1 year, we are now performing 4D flow as well. Yeah, but no black blood sequences.
Okay, the next question is, are you able to have a good view on the aortic arch to rule out aortic stenosis, something challenging on ultrasound?
Yeah, this is a very interesting topic. So sometimes it might be not that successful to visualize the aortic arch in a perfect parasagittal view. And that's what we want to find out with our 4D flow sequence now, because due to the flow patterns in the aortic arch, maybe it's easier to diagnose a stenosis by the flow patterns instead of only morphological imaging. But I can't give a good answer, because this is work in progress, and we want to see if the 4D flow works better on it than the parasagittal view, the anatomical cine mode. Yeah, we will see. I don't know, but sometimes it's not easy to assess a perfect parasagittal view of the aortic arch.
Great. Another question. How much has fetal cardiac MRI changed clinical practice at your centers? Is this only used for certain patients' diagnosis, or is this primarily used in a research setting?
So in our case, it's primarily used as or in a research setting. It is all patients that are referred to our prenatal department with suspected congenital heart disease are are offered to get a MRI, and the uttermost of them wants it, and yeah, so from this side we get our patients.
Yeah, it's the same at our institution. It's often for research purposes, but we are in close conversation and discussion with our Center for Congenital Heart Disease, and so stepwards we are moving to implement this method in clinical routine. But I think this is still a long way to go, because you have to convince your colleagues that this is a good method and that it works. And but you can easily do it by showing them good images, and then they are happy, and they will provide many patients for you, I guess. So we are on a good way, but it's quite hard work to do, because of course they rely on echocardiography, which is very good, and this new method has to be implemented. But we can all work on it.
All right. For the sake of time, we need to get to the last question actually, and this is one that Fabian has the chance now to ask. Or shall I just read it out?
We have reserved for Fabian to select a nice question for the final question.
Only if you want to. Otherwise, I will just read it out because it was pasted here. Are there recommendations from you how to get a good signal to noise ratio at 3 Tesla?
Yeah, not too thin image slices. Maybe 1 point. Yeah, it's all. Yeah, the problem is always the breath hold of the mother, because it's only, let's say, for 12 seconds, 30 seconds, but not much more, and then you are limited in modifying your parameters, and so the SNR is limited in some way. That's always a compromise you have to do, and the limitation is definitely maternal breath hold. Yeah, and within these 12 seconds, you can change your parameters as you like, but I think the SNR is just limited. It's not open end. It's not like knee MRI, where you can invest 7 minutes for a sequence. So you have to respect your limitations, I guess.
Okay, thank you, Björn. Thank you, Thomas. Thank you all for your active participation. And we have to stop now. There are many open questions still. However, we will take all those questions into the next session, okay? So, and we also want to let you know that you can, I share my screen for last time, that you can send all your questions that you still have in your mind to us. So we will collect them and bring them as a topic into the next session.
That's happening on 15th of February. The title of it is Mastering the Technical Challenges of Fetal CMR Planning. We had many technical questions. We tried to raise some now, but we reserved some of the questions, especially regarding flow, for this next session, because it was just too much to answer now. We appreciate the interactive discussion. The next session will be hosted by Shuo Zhang, who is a clinical scientist of Philips, and Luis Gonçalves from Phoenix Children's. As Heide said, any questions that you have in addition, you can post them in the chat now. We will reserve all these and save all these questions, or you send them to Heide, and her email address is shown here. We will put it in the chat in a minute. And the registration for this next session is open now also, and we're going to copy the link into the chat now as well. So yeah, we thank you all for the participation, and very much enjoyed this webinar, and especially the very interactive discussion.
Thank you very much. Bye.
Thank you all.
Bye-bye.
Bye-bye.
Thank you. Bye.